Good evening to one and all present here for today's webinar. We will be starting. On behalf of all the Nurses Labs team, we welcome you all today. Today's topic is based on World Hepatitis Day, as recognized on the 20th of July. Thank you all for taking your time to be part of this webinar. We will begin. I'll introduce the speakers for this evening. Uh, I'm honored to introduce our first speaker, Mrs. Jesslyn Russell. Mrs. Jesslyn Russell is currently working as a deputy nursing staff in Norfolk and Norwich Hospital, UK, in the Children's Assessment Unit. She has also worked in JIPMER as a staff nurse in the adult and pediatric departments. She has a total of more than 13 years in the field of including a nursing clinical instructor at Apollo College of Nursing, Andhra. Ma'am has completed her BSc Nursing at Apollo College of Nursing, Chennai, MSc from College of Nursing, Madras Medical College, Chennai, and is now pursuing her MSc in Advanced Professional Practice, School of Health Sciences, University of East Anglia, UK. Mrs. Jocelyn has also completed her examinations for the MBA in Hospital Management at Pondicherry University and PG Diploma in Hospital Management at Madurai Kamraj University, India. She has completed her ACP course in 2025 and she plays a major role in clinical audits and is involved in research activities and has developed individualized pediatric emergency care plans for oncology children. We welcome you, ma'am, and over to you.
Good evening, everybody. Thank you for the vast introduction. And thank you for allowing me to share this platform. Let me try to share my screen. I'm Jesslyn. I'm going to talk you through myths versus facts and breaking down the hepatitis stigma. Let's start with the basics. What exactly is hepatitis? I hope everybody know this. The word hepatitis simply means inflammation of the liver. Now, this inflammation can be triggered by different factors, most commonly viruses, but also toxins like alcohol and certain medications, and even autoimmune responses where the body mistakenly attacks its own liver cells. In India, viral hepatitis is particularly significant due to the high prevalence of waterborne forms like hepatitis A and E and bloodborne forms like B and C. There are five major types of hepatitis A, B, C, D, and E. Each has unique modes of transmission and implications for prevention and treatment. For example, A and E typically spread through contaminated food or water, while B, C, and D are transmitted via blood and body fluids. We also classify hepatitis based on duration. Acute hepatitis, which is short term and often resolved on its own, especially in types A and E. Chronic hepatitis, which can result from types B and C, lasts longer than 6 months and may lead to serious complications like liver cirrhosis or cancer if not managed properly. Understanding this foundational knowledge help us better equip ourselves to spot warning signs early, educate patients, and reduce stigma. Now that we have seen what hepatitis is, let's take a look at the scale of its impact both globally and here in India. Worldwide, nearly 354 million people live with chronic hepatitis B or C. That is a staggering number, especially considering these infections can quietly damage the liver over many years without any obvious symptoms. And despite effective treatments and vaccines, a huge gap remains in terms of awareness and access to care. Turning to India, the picture is particularly complex. We have a high prevalence of hepatitis B and C, often linked to factors like unsafe medical practices and limited access to screening. Hepatitis A and E, on the other hand, are still common in children due to poor sanitation and unsafe drinking water. What's especially concerning is the low awareness among the public, even among some healthcare workers. Many don't realize hepatitis B can be prevented by a vaccine, or that hepatitis C is now curable with oral antivirals. And while India has included the hepatitis B vaccine in its universal immunization program, coverage and update remain suboptimal, especially in rural areas. As nurses, this is where we step in, not as caregivers, but as educators and advocates. Next, we will see about the myths and facts. So, this section is always a favorite because it gives us a chance to challenge common misconceptions. Let's begin with the first one. Many people think hepatitis is the same as jaundice, but that's a misunderstanding. Jaundice is actually just a symptom. It shows up when bilirubin levels rise, often due to liver inflammation. Hepatitis is the underlying condition that causing that inflammation, not the same thing at all. Another myth is that only alcoholics or people with risky lifestyles get hepatitis. In reality, it can affect anyone. Viral infections are a major cause, and even things like contaminated water or unsafe medical procedures can lead to infection. This myth not only misinforms, it promotes stigma, and that's something we must actively combat as healthcare professionals. Then there is the belief that hepatitis C and B are spread through the casual contact, like hugging or sharing utensils. That's simply not true. These viruses are transmitted through blood, sexual contact, or childbirth, which means casual social interaction doesn't pose a risk. The dangerous myth is that vaccination is not necessary, but the hepatitis B vaccine is proven safe and effective. In fact, WHO strongly recommends it, and it's even part of India's universal immunization program. Increasing coverage can dramatically reduce infection rates. What about herbal remedies? While traditional medicine has cultural value, there is no clinical evidence supporting its use to cure hepatitis. We must promote evidence based treatment, especially for chronic infections. Another outdated belief is that hepatitis B and C can't be treated. Today, hepatitis C is curable in over 95% of cases with modern oral medications. Hepatitis B can be managed with antivirals to prevent progression to liver damage. People also believe children don't get hepatitis, but in fact, hepatitis A and E are common in children, especially in areas with poor sanitation. This highlights the need for preventive education and sanitation awareness. Lastly, the myth that diet doesn't affect hepatitis really misses the mark. Nutrition plays a key role in liver health and disease progression. Malnutrition can worsen the outcomes, and certain foods can place added stress on the liver. In summary, our role as nurses goes beyond clinical care. We are also educators. Tackling these myths with clarity helps reduce fear, stigma, and misinformation among the public. Next, we'll see why myths matter. Let's talk about why myth busting is more than just a fun exercise. It's absolutely essential for patient care and social well being. First, mental health. When people believe myth, like thinking hepatitis only affects immoral individuals, they internalize stigma, feel ashamed, and may isolate themselves. The emotional burden of having hepatitis, especially when misunderstood, can lead to anxiety, depression, and even suicidal thoughts. As frontline healthcare providers, nurses are often the first to notice this distress and offer compassionate support. Next, healthcare avoidance. Myth can delay or prevent diagnosis and treatment. For example, someone may believe herbal remedies are enough or fear discrimination at a clinic. This avoidance shows the disease to progress unchecked, increasing the risk of liver failure or cancer. We need to create environments that encourage openness where people feel safe seeking help without judgment. Lastly, workplace discrimination. Misconceptions around transmission lead to unfair treatment. Patients, even healthcare workers, have been excluded from employment or education opportunities simply because others wrongly assume hepatitis spreads through casual contact. That's not only ethically wrong, it's illegal in many contexts. Nurses can advocate for fair policies, educate colleagues, and create inclusive spaces. So, addressing myth isn't just about correcting facts, it's about protecting lives, dignity, and equality. Let's keep breaking these down one conversation at a time. And next one is breaking the stigma around hepatitis requires intentional action. Nurses are uniquely positioned to lead this change. First one is about education campaign. So these are the frontline defense against myths and misinformation. Maybe posters in clinics, outreach in schools, radio spots in regional languages all help normalize conversations about hepatitis. When communications are informed, they are when communities are informed, they are empowered. Second, patient stories. There is no substitute for the power of lived experience. Sharing patient journeys, especially of recovery, resilience, and acceptance, can humanize the condition and foster empathy. Wherever it's in support groups, video testimonials, or community talks, real stories challenge stereotypes and show that hepatitis is a manageable condition, not a moral failing. Third, community engagement. Nurses can collaborate with the local leaders, NGOs, and religious institutions to host awareness events and distribute materials. These trusted voices can help reach marginalized populations and ensure messages are culturally sensitive and relevant. And finally, healthcare training. Sometimes stigma starts within the healthcare system itself. Training modules for staff, from doctors to ward attendants, can help correct biases and ensure compassionate, non judgmental care. Role playing, myth busting quizzes, and clear protocols make these trainings practical and effective. Together, these strategies create a ripple effect from hospital wards to villages, reducing stigma and improving health outcomes. As nurses, we are not just caregivers, we are catalysts for change. So as we come to the end of the session, let's reflect on what we have explored. Hepatitis is not just a medical condition, it's a social issue wrapped in misunderstanding and silence. Through today's talk, we have unpacked what hepatitis really is, highlighted its burden globally and in India, dismantled persistent myths, and examined the toll these misconceptions take on mental health, access to care, and dignity. But more importantly, we have looked at how nurses can change that story. You're not just caregivers, you are educators, advocates, and change makers. From community clinics to urban hospitals, your voice carries weight. Every patient interaction is an opportunity to educate, every myth corrected is a step toward better care, and every stigma challenged is a lifeline to someone suffering in silence. Thank you very much for listening, and thank you, Nurseslab, for the opportunity given. Thank you.
Thank you, ma'am, for that brief introduction yet detailed um, topic on busting the myths versus the facts about hepatitis. I would like to introduce to you our second speaker for this webinar, Mrs. Anshul Mehra. Mrs. Anshul is a dedicated and accomplished ICU nurse with over 10 years and 6 months of experience in critical care. Currently, she is working at the head nurse as a head nurse in the hepatology and liver transplant ICU at Medanta Hospital, Gurugram, Haryana. She has completed her BSc nursing from the Himachal Pradesh University and has led specialized ICU care for liver transplant and hepatology patients since. Ma'am has skilled in leading multidisciplinary teams and ensuring compliance with JCI and NABH standards. She has been awarded in Transcon 2024 for CNE and Advanced Skill Workshop on Organ Transplantation and achieved first rank in the liver transplant specialty course in the year 2024 to 2025. We welcome you, ma'am.
Starting today, my topic is autoimmune hepatitis and its outcomes and emerging therapies. So we can understand the prognosis and new treatment horizons, which is under trials, and what the standard therapies we are going through for the autoimmune hepatitis. So we just go through a normal overview of the autoimmune hepatitis. That what is autoimmune hepatitis, what are the causes, and any kinds which are triggering to the patient to get a autoimmune hepatitis. So autoimmune hepatitis, it is a kind of a chronic inflammatory liver disease, which mistakenly in which our immune bodies mistakenly attacks our hepatocytes. Hepatocytes are healthy liver cells which we are having, which may lead to cirrhosis, liver failure, and hepatocellular carcinoma, means to the liver inflammation and damage to the liver. Then the mainly causes of the autoimmune hepatitis is unknown, means there is a multifactorial causes, and it may be triggered by many things like genetic predisposition, environmental factors. In genetic predisposition, it mainly affects due to the two types of HLA, that is HLA-DR3, HLA-DR4, which is a kind of type 1 of autoimmune hepatitis. And many environmental factors like infections, toxins, drugs, infections like hepatitis A, hepatitis B, and hepatitis C, which are mainly affecting to have a autoimmune hepatitis in a patient. So these are some of the factors which
Sorry for disturbing.
are
Actually,
triggering background for the autoimmune hepatitis. The autoimmune hepatitis is very common in the females. 70 to 80% is found in females. As I've told you, there are two types of autoimmune hepatitis. There are autoimmune hepatitis. So the type 1 is AIH, most common. Will affect the teens and adults, and type 2 it is mainly in the children. So it is mainly in the children, and it have auto antibodies, that is LKM1 and LC1. So LKM1 is liver kidney mitochondrial 1 antibody, and in type 1 AIH we have auto antibodies like ANA, anti-nuclear antibody, and SMA, smooth muscle antibodies. So these are the things which auto antibodies we have in two types of autoimmune hepatitis. Then it is mainly asymptomatic in the early stage, but when it is present, it may show you a normal symptoms like joint pain, jaundice, which is yellowing of the skin and eyes, dark urine, pale stools, it fatigue may similar to the hepatitis. Then we can diagnose it with the blood test, like if a patient have a elevated liver enzymes ALT AST with the high IgG, and we will go for the auto antibodies like ANA, asthma, and LKM1. And so by this we can know the ranges of the antibodies which will show it is autoimmune hepatitis or not. Then we have to go for the liver biopsy as well, which confirms the inflammation of the liver or any immune cell infiltration. So this is just a small overview of this is just a normal overview of the autoimmune hepatitis. Next we have the of outcomes of the autoimmune hepatitis. So we have good outcomes also, as well as we have poor outcomes also. So in a good outcomes, we just have a long-term survival and remission. And in a poor outcomes, we have relapse, progression to the cirrhosis, and acute severe or fulminant hepatitis. So in a remission, there will be a good response when you are started with the medications in a remission. So mainly we'll start with the prednisolone tablet and medication, in that is first line therapy medicine. So in that, after taking a first line therapy, we have a normal liver enzymes, that is ALT and AST. No active inflammation when we undergo when the patient undergone to the liver biopsy. And 90% approximately 90% proper treatment is done with the steroids like prednisolone, and it may be achieved within 6 to 24 months. It will according to the patient conditions, that how much time it will take to achieve. But if the once the remission is achieved, it is a good response for the patient. Then we have to come for the relapse. Relapse is a kind of poor uh, outcome of the autoimmune hepatitis, because in relapse, after stopping the therapy 50 to 80%, we have to reinitiate with the treatment again. But in this, we have to reinitiate the first line therapy with the second line therapy, in which we can add our tacrolimus and mmf. So, in this, liver enzymes rise even after stopping the medication, and it is may need a lifelong immunosuppressants. So, we will give it with the first line therapy and second line therapy, means prednisolone, tacrolimus, and with MMF. Three of them will be required for the lifelong. Then, if the autoimmune hepatitis is having progression to the cirrhosis, once the inflammation is there, so it will have fibrosis of the liver, of the liver cells, then it will become cirrhotic. So 30 to 50% people are there, when they came at the stage, they have already a cirrhotic liver, where they came to know it is AIH, and already the liver is cirrhotic. So there are very much uh, means poor outcomes in the this cirrhosis of liver, once the it is progress to the cirrhosis. Then we have a acute severe or fulminant hepatitis. If the patient is having rapid liver failure, the enzymes are not getting normal, and the INRs and bilirubins are elevated, the encephalopathy grades are increasing. So the we only need a liver transplantation, which is the last step, but we have a poor outcomes for that. Then we have a long term survival, which is a good outcome with early treatments and early recognition or diagnosis. We have 10 year of survival with more than 90% of patients. Quality of life is become near normal, and it requires lifelong monitoring. The medications which are going on are on lifelong monitoring. So these are the outcomes of autoimmune hepatitis, good and poor also. So we will more focus on remission. If the patient have a remission, good response, it is more good for the autoimmune hepatitis patient, because in others it's all progressive to the poor outcomes. Then, what are the current standard treatments for which we are right now we are using in our medical lines for the patients to treat the AIH patients? So the standard therapies we right now we are using are prednisolone, which is generally a immunosuppressant and a kind of corticosteroid, which is a first line treatment. And azathioprine, it is a kind of T cell suppression, which is used if which is used for the T cell suppressions, and it will be given with the help with the steroids. Then the second line therapy, which is mycophenolate meftal, which we give if we have a relapse. If even after giving the medications, patient is not getting the enzymes on a ranges. So we'll start with the mycophenolate meftal. It inhibits the lymphocyte proliferations, and it is given to the patients who are intolerant to azathioprine, as mostly patients are on prednisones. But if any patient is getting azathioprine, so for that we will use the mmf. Then cyclosporin and tacrolimus, these all both are the calcineurin inhibitors, and it is mainly when we firstly we start with the tacrolimus. Whenever we will give the tacrolimus, if it is okay, there is no toxicity for the tacrolimus, we'll move to the cyclosporin. But mainly we have to see the renal function test, the nephrotoxicity which is going on. If the patient is having nephrotoxicity, we will avoid the cyclosporin and tacrolimus. Then the last is the liver transplantation, which is the current standard treatment going on, means the organ replacement, which is at the end stage disease, or if the patient is having permanent liver failure. So these are the current standard treatments which are going on right now. And what are the emerging therapies mainly? These are the current standard treatments. Now we'll go through a emerging therapies which are on trials, on case series, on pilot studies, and many early phase trials. So we can detect the AIH and treat the AIH in better way for the good outcome and for the good remissions. So now I'll start with the emerging therapies. First is the rituximab. So rituximab is an anti-CD20 monoclonal antibody. It mainly depletes our beta cells and reduces the uh, anti autoantibody productions. It is in the pilot studies going on, and we are using this also. It helps the steroids and refractory, or in the patients which are intolerant to the azathioprine. Then we'll have vedolizumab, which is a kind of protein integrin, and it mainly blocks the gut of the lymphocytes, and it reduces the gut and liver inflammation, as the patient is having inflammation, so it helps in reducing the inflammation of the patient. It is limited use in overlap syndrome. Some of the syndromes we can use, still we have not started with this medication, but it can target the immunosuppressants to lower the systemic side effects which is happening with the other medications. Then we have a abtacept, which same as inhibits the T cells, cause stimulation, and it is reduces the liver inflammation. It all help in the reducing the first step, that is liver inflammation, which is happening. Then sirolimus and everolimus. So sirolimus and everolimus, these are T cell proliferating, and these just blocks the T cell proliferation and cytokinins productions, and it is mainly used post transplant patients of AIH, and the patient who has undergone AIH and who has gone post transplantation after AIH, having AIH. So we are using everolimus in that, because it helps in the T cell proliferation, which helps to for the more good outcome for the liver transplant patients. Then tocilizumab, this is IL-6 receptor antagonist, which is used same for mediating the pro-inflammatory signaling. If the patient is having inflammation in the liver, then we have using the tocilizumab. It is theoretically in AH going on, but still not used uh, in the field right now. Then same is the IL-12 receptor, that is ustekinumab. This is a very used in a very rare case reports, and it is having a very means it modulates the Th1 and Th17 pathways, by which we don't have the inflammation, and immunity of the immune cells will become they will just see the molecular mimicry of the liver cells. Then low dose interleukin 2, it is a cytokine therapy. It regulates the T cells, and it promotes the immunity tolerance of the patient. It can be used in the early phase. If the patient is detected early with the AH, we can start the patient with this to balance the immunity without giving any kind of second therapy like immunosuppressants, which we usually start in the right now. So others are JK inhibitors. It is a small molecular inhibitor which we use, and it just block the signaling pathway, and it helps in modulation of the cytokinins. It is not yet tested in autoimmune hepatitis, but the studies are going on. The next is a cell therapy, which is tolerogenic dendritic cells, which is mainly used in inducing the antigen specific immune tolerance, and it is going on in the experimental for the phase 1 trials. Just phase 1 trial is going on, and it can allow the long term remission without going to the second line therapy or to the relapse. So it is just a phase 1 trial is going on in this. Then probiotics. Probiotics is mainly to modulate the gut and liver axis, mainly to reduce the inflammation of the gut and the liver. So these are also pilot studies are going on in various areas, and right now it has very few side effects, which is the pilot study which has done. The next is the mesenchymal stem cells. This is a cell therapy. It is helpful in the tissue repairs and immune modulation. So it is mainly done in the clinical trials of liver diseases like chronic liver diseases and ALF, in the AI, because of AIH. And the main thing is it helps in the regeneration of the liver. It supports to regenerate the hepatocyte, the healthy liver cells. Then IL-17 inhibitors, these are monoclonal antibody. It inhibits the Th17 mediated inflammation. It is also under investigation and in liver diseases, and potential benefits are that it will drive on the AIH subtypes with this. Then anti-TNF agents are biological class which inhibits the TNF, a key pro-inflammation. It is very rare of label use, may help in overlap syndromes, and mainly when the liver toxicity is happens. So we'll go through the anti-TNF agents. So these all are the emerging therapies which is under the trials, pilot studies, phase ones, experimentals, which is going to become in a future to reduce the chances of AIH, which is because sometimes AIH means just I have told you, people like 30 to 40% people come with the liver cirrhosis. So liver cirrhosis is the last stage of the fibrosis, necrosis of the liver, which only requires a liver transplantation. So mainly these are the emerging therapies which we can start with the AH if it is possibly helpful to the AH to detect the AH in a more possible early way. So next is the what are the future directions which through we have to go. So if we are targeting the immunotherapies like the development of biologicals, so that we can remove the second line therapy like immunosuppressants, we can replace them. Tolerogenic approaches, we can restore the immune tolerance by the low dose interleukin 2 tolerogenic dendritic cell therapies. And the next is microbiome modulation. We can explore the gut liver axis by using the probiotics. Uh, fecal microbiota transplantation. We will personalize the medicines by using the biomarkers like cytokinins and genetics, which will help us to predict the outcomes. We can make the steroid-free regimes and improve management of overlap syndromes like we having in primary biliary cholangitis, so that we can have the mean we can differentiate between the AIH and these all symptoms. Then we will use the digital tools and AI integration. We can use to to monitor the disease and the treatment optimization, and we have to refine the risk of stratification for the treatment intensity and duration, because as we are saying, remission also needs 6 to 24 months for the patient to have a good outcome. So we, with all these future directions, if it is possible, we can shorten the duration of the patient's treatment. So there are some key takeaways. So we have to need the randomize the control trials to validate the biologicals and novel immunosuppressants, non-invasive biomarkers for diagnosis and monitoring, personalize the medicines with the HLA allotype, like I have said, HLA DR3 and DR4, which is in the type 1. So we have to personalize the medicine according to the type of AIH, and we have to focus on the improving remission rates, because remission rates will give the good outcome in all the AIH patients. So these are the references to which I you can reference Gastroenterology and Hepatology of 2024, Cleveland Clinic 2023, Johns Hopkins Medicines 2024, and the Mayo Clinic.org diseases. So these are all the references. Thank you so much for the attention, and any questions, please let me know.
Thank you, ma'am. We will move on to our next speaker, Mr. Alfred Solomon David. I have the privilege of introducing him here. Mr. Alfred Solomon David is an assistant professor at the Savita College of Nursing, Chennai. He currently leads the academic instruction, clinical supervision, and curriculum development in his field. He has a total of more than 10 years of experience in the field of psychiatric nursing and specializes in research focuses on the evidence-based practice and compassionate patient care. He is committed to inspiring the next generation of nursing professionals. Sir has completed his BSc from Garden City College of Nursing, Bangalore, under the Rajiv Gandhi University of Health Sciences, Karnataka, and his MSc and PhD in the Savita College of Nursing, Chennai, Tamil Nadu. Sir has had many research publications in Scopus and Web of Science and international journals of scientific research. He is a certified mental health care provider by NIMHANS and a certified psychological first aid giver from Johns Hopkins. He is also certified in mindfulness based cognitive behavior therapy. He was awarded the Best Young Faculty Award by Nobel Research Academy, Puducherry, and the Best Educator Award by IAFER. We welcome you, sir, for this evening.
So, good evening, one and all gathered here. It's my pleasure indeed to be a part of this Hepatitis Day celebration. First of all, I would like to thank the organizing committee members and the fund who is comparing for this great opportunity. I thank you all for taking your valuable time to be with us today. So, for the speaker that comparer has introduced me in a nice manner, I thank you for that. So, being a mental health profession, I'm happy to be sharing the content about the hepatitis. That's a prevention, care, and the patient education with evidences and recent advances. So, it's my pleasure to be with you. So, let's go into the content directly. So, the speaker who spoke previously has spoke very much and had given the good introduction about the hepatitis and the great details about the hepatitis. So indeed, it's my formally, I just want to I just want to give an introduction about hepatitis. It is a liver inflammation commonly caused by hepatitis viruses A, B, C, D, and E. Liver inflammation, as we know, but it is very serious in impacting the lives of the patient. So we'll have the this 20 minutes of the session. So when we talk about the global burden, over 350 million people live with chronic hepatitis B and C. Hepatitis B and C account for more than 1.1 million deaths annually, mostly from cirrhosis and hepatocellular carcinoma. So this is the latest data which is given by the WHO on 2023. So this was detailedly discussed by the previous speaker, and it was an excellent presentation. He has given almost. So when I talk about the nursing emerging role, as we the nurses, we have the global responsibility of dealing any kind of disease. For example, the COVID pandemic. In previous years, we showed our responsibility, and we played a major role in preventing and identifying and managing the cases of COVID pandemic, despite of the critical situation and prone to infections. So here, when you talk about the nurses' emerging role, nurses are pivotal in early identification. So it is a global slogan of the nursing: identification, vaccination, and coordination, public health education. So we the early, that is early identification, and we well known and trained about vaccinations and care of coordination and public health education. We talk about the nursing role in the prevention. First, we talk about the vaccination program. When you talk about the hepatitis B vaccine, it is 95 point percentage effective in preventing the infection and chronic disease. And we have the evidence from the Lancet Global Health, the 2022. This journal is a high impact 3.2 impact journal. This journal shows the nurses-led vaccination program improved hepatitis B vaccine coverage from 62% to 91% in the rural clinics. So this is all about the evidence of this vaccination program. So the vaccination program has shows the 95% of the success. 4 has followed by 3 doses. This is the very well known information for the every nurses and as well as the pediatric students. So here the one more main role of the nurses is breaking the cold chain. Nurses ensure cold chain maintenance and adherence. So when you talk about the cold chain maintenance, it is not the very new topic for us. It is just it's well known that hepatitis B vaccines are high tolerate to the these vaccines are temperature sensitive. So when you have to store it at 2 degrees Celsius to 8 degrees Celsius. This may give the protection to the property of the vaccine, and it reduce the immunogenicity. So once the immunogenicity is not broken, the vaccine would be active and it will be efficient to prevent the infection. This is all about the main role of the nurses. Even though it is a small step, this will bring a better change in the administration of the vaccine. So these three things has to be considered here. And when you talk about the infection control, it's well known that we know the infection control measures. So every hospitals and every country and even every nursing council has their own infection control policies. So effective waste management and hand washing techniques and PPEs and a person that is a personal protective equipments and vaccinations. So this all reduces the infection. So here the adherence to the standard precaution reduce the occupational exposure by 60%, 65%. So this is the data from American Journal of Infection Control. Even NHS has their own policies. Even India has their own policies. Even NABH has their own policies. So safe injection practices, personal protective equipments, and safe face all this brings enormous changes in controlling the infection of hepatitis. So this is all about the infection control. And when you talk about the screening and risk identification, so nurses lit mobile screening units. So this is something very new for me because previously I'm not aware about this. Being a psychiatric professional, I learned something about the telemedicine previously. During the COVID pandemic, we had a chance of conducting this telemedicine through online for the community areas through NIMHANS. We had such a programs, but it is very interesting that when I come across this hepatitis, even they have the nurses-led mobile clinics in the foreign countries. So here we have the data from the BMC Public Health 2023 journals. They have given vast details. Even you can go for the reference. So here the England contact tracing. They have a case management contact tracing. So here they have a testing the patients for HP, and this success rate was up to 72 to 94% of coverage was there, and vaccination was done 98%. So this program, which was done by government of the England by using this mobile clinic, 98 70 to 98%, they have achieved the vaccination. So again, the even the Sydney Community Clinic, so they have the triage care and planning referrals. So for the chronic HPV patients, so here they brought a outcome of high patient satisfaction, initiated therapy, and surveillance. So since I want to make it as a short slide, I didn't plot all the data, but the reference are given inside at the reference slide. So later you can go for the journal and you can go for the detailed evidence study. Next, I can come across. I came across UK GP-based clinics. So here the review under consultant oversight. So here they have appointed a consultant and they have the mobile clinics, and they have came across. They too focused on HPV chronic patients. So here they shifted the care to primary. So they reach the doorsteps of the patient, and 93% of patient favored because of this program. So every country has their own programs. So when I came across the BMC Public Health, so it was an interesting data I got here. So England, Sydney, and three countries I have measured. Even developing countries, they have focusing on such a program. Here, the major role was played by the nurses. So they done here they were screening, they were vaccinating, and they were reporting the complications. So this was the major outshift for the nurses regarding this prevention of hepatitis and managing of hepatitis. So next, the major role of nurses is a nursing role in care management. So here, as I mentioned, early detection. So nurses screen for jaundice, fatigue, hepatomegaly. So these all are the well-known terms. I believe all are trained professionals, so I don't want to go much in detail about the definitions. So here the using of the point of care testing. So when you talk about the point of care testing, it is one of the important concept in diagnosing the hepatitis. So here the high burden is low access. So the rural population often have limited access to centralized lab and specialties. So still in India, the villages, peoples in the villages, they are not aware about what is hepatitis. Or when I talk about the community, still if you go to the community area, if you go to the villages, if you see the peoples, they mention the liver disease as a stomach pain. So that is a condition still now existing in India. So they don't know to differentiate whether it is because of stomach issues or some ulcer issues or some other issues. So anything something related to the abdomen, they consider that as abdominal pain. So in such a cases, nurses plays a major role in identifying the early identification of the disease. So here the nurses screen for jaundice, fatigue, hepatomegaly. So if the basic nurses, even the student nurses, have the vast idea about this, they can easily diagnose it. Here the journal Insight, the Nursing Research and Practice 2022, emphasize the nurses' competency in interpreting the LFT and referring the high-risk patients promptly. So once all the students are equipped and have vast knowledge to identify the LFT findings, it will be easy for them to identify the risk the patient is whether it's going to infect or in acute stage he can able to identify, and the patient can be easily treated before the severe complications. So I consider this as a. So when we talk about the medication management, the main job of the nurse monitor adherence to direct antiviral, that is DAS for hepatitis, and looking for the cure rate, that is 95 to 98% cure rate they are achieving nowadays. And in case of hepatitis B, monitor for tenofovir. In case of hepatitis T, DAS, direct acting antivirals such as sofosbuvir and plus velpatasvir and lepsovir and sofosbuvir. So these all are the commonly giving long acting antiviral medications. So this can be administered properly with the policies and protocols. So that's 95 to 98% of cure rate can be achieved. That because of the hard work of the nurse. So that has to be considered. So when you talk about the recent advancement in the long-acting antiviral injections, so Nature Review Drug Discovery 2023 journal. So these journals state that long-acting antiviral injection for hepatitis B are under the trial. It may shift the focus to monthly nursing follow-ups. So these all are the recent advancement. So the recent advancement are forwarding towards the long-acting antiviral injection. This may help in early cure or prevention rate, or it might be effective in treating the patients with hepatitis and to come with better prognosis. So the third one is infection control in clinical settings. So preventing the cross contamination in dialysis units, ICU, and other places in the hospital. It's obviously already well discussed about this. So use of nurse-led surveillance protocols reduced iatrogenic transmission in hepatitis C units. So this was the information in the Infection Control and Hospital Epidemiology Journal. They state about the nurses-led surveillance protocols. So when you develop a specific protocol for hepatitis, even many of the hospitals are having now. So this may reduce the iatrogenic transmission of hepatitis C or hepatitis B, anything. So the protocols may help in reducing this infection. So my opinion as a nurse, if you do research in everything and if you come with a hypothesis, and once the hypothesis is proved, so your clinical care will be better. So the what is done in the paper and the data that has to be transmitted to the clinical water settings, I hope this will bring the better prognosis. So next is palliative and psychosocial care in the hepatitis. Obviously, psychosocial care is very, very essential since nurses assess the emotional burden, stigma, and coordinate the mental health referrals. So most of the time, clinical picture and the clinical treatment is very, very essential. But most of the time, the psychosocial care is skipped in the patient's conditions. So obviously, we supposed to address the psychosocial need of the patient and the palliative need in case of severe conditions. So here we have a Journal of Clinical Nursing. So nurses integration of telenursing during COVID-19 improved patient engagement and mental well-being. So here the telenursing during the COVID-19 improved the patient engagement and mental well-being. So nowadays mental health has a lot of initiative which provides an door-to-door care. No need to go for a psychiatric clinic, or it's not that myth has slowly eradicating. Even in India, it is getting eradicated. So it's going to the counselor and getting consulting to the psychiatrist is not only a psychiatric disease. So those myth is eliminating nowadays. So even telenursing are much focused during COVID-19, as we mentioned. Even government of India and all the state governments had initiation of this COVID-19 counseling. So this telenursing, this plays a major role. I want to say, mention few, even in Tamil Nadu. So there's palliative and psychosocial care for the hepatitis. As a nurses, you can initiate, even you can start your own initiative or startup. So anything can be done based on the psychosocial care. And as a mental health profession, I can refer you. You can train a CBT and you can train a counseling or anything. You have a lot of even Coursera. You have many courses, so you can get trained to that. So this is all about the palliative and psychosocial care. So when I talk about the mental health concept, usually they will be having the fear of life and uncertainty about the future and question mark about the rehabilitation. So repeated thoughts, this may create the anxiety and as well as the mild depressions. Sometime in the case of palliative, they may go for the severe depression. In such a cases, with the help of questionnaires, you can identify the level of the depression or stress or anxiety that should be treated through many. We have many therapies, and this is not a right forum to talk about the many psychiatric therapies. So with this, I can end the palliative and psychosocial care. And the main role of nurses, the final, these all are my last slides. So role in patient and family education. So the very first concept is disease literacy, explain the difference between the acute and chronic hepatitis and the risk factors outcome. This can be explained through local languages, visual aids, and teach back techniques. So these can be taught to the patients. We are well versed in making the AV aids and giving health education. So next is treatment adherence. Nursing education improved DAA, that is adherence to 93%. So Journal of Hepatology or Hepatology Nursing states that treatment adherence is 93% achieved in DEA. And the use of mobile apps and text reminders for hepatitis B follow-up. So this all well known. So the mobile apps will give you the reminders and the text reminders. This will give the alarms for taking the medication. So this will bring you the adherence to 93%. Sometimes even I miss my medications. So everyday running life, we cannot follow that. So these reminders, and even we have the apps for drinking water. So this all brings the special change and it improves the treatment adherence. And lifestyle counseling, so promoting the liver protective diets and alcohol abstinence. So obviously the lifestyle management is very, very important for liver's health. So less fat diet and cutting the alcohols and liver protective diets, all things has to be taught to the patients. And recommended vaccination for the family members of hepatitis B positive patients. So these supposed to be taught to the patients. So next is transmission preventing at home, separate toothbrushes, razors, use of gloves for wound areas, safe sex practices, using of condoms, and educating the couples on prevention. So this all helps to prevent the hepatitis. So when you talk about the stigma and support, obviously every disease has some stigma and it's supposed to be supported. So supported group led by nurses improved mental health scores. That is PHQ-9 is a questionnaire specially meant for hepatitis B patients. So this was mentioned in International Journal of Mental Health Nursing 2023. And these questionnaires can be effectively used. Most of the time questionnaires, since because it is verbally written, it is most of the people they skip many questions, but when you practice the questionnaires sincerely you can get the better output. So International Journal of Mental Health Nursing, you can go and refer the PHQ-9 questions, which will have a great source of knowledge. And next is a peer-led family educations model now being plotted. And obviously now the YouTube is one of the major health education. Even everyone become Google doctors nowadays. So putting your right content by nurses and a professional content will help the patients to eradicate the stigma, and it supports the patients to adhere with the treatments. So with this, I conclude the role of nurses. I hope you all have gotten a little knowledge with this 20 minutes session. So here the key takeaways for this today's session is nurses are the central agents in hepatitis prevention, care, and education with empathy, evidence, and education. So when something the practices are old, your evidences will make you as a new person, and every day you're learning, and every day you're innovating something. So stick on evidence. So this is my kind suggestion for all the emerging nurses and as well as the existing nurses. So by doing this, the nurses can reduce the global hepatitis burden. And recent shifts in the practices, now the AI, when you mining the data of the hepatitis B, even I used AI tool to mine the data today. So AI, telehealth, and long-acting antivirals and nurses-led clinics. So these all are the recent emergent. Even yesterday, I never know all these details. When I got an opportunity to present a session on role of nurses in hepatitis, I got all this information today. And as a nurses, we can in this hepatitis day, we can promise that we can contribute something in prevention of the hepatitis and management of the hepatitis. So these all are the reference WHO Global Hepatitis Report and Journal of Viral Hepatitis, Lancet Global Health, American Journal of Infection Control, BMC Public Health, Nature Reviews Drug Discovery, Journal of Clinical Nursing, International Journal of Mental Health Nursing. So these all are the journals I came across for this 20-minute presentation. Even you can use this for your further reviews. So with this, with a grateful heart, I thank the organizing committee members for providing me this opportunity.
Once again, thank you to all the three speakers for this evening. Thank you, sir, for the detailed explanation on nursing roles in hepatitis prevention.